With your hosts, Lily Mundy, Raj Parikh, and Kyle Sanniec, this is the award-winning PRS Journal Club podcast.
Hi everyone, and welcome to the December 2019 edition of PRS Journal Club podcast. I'm Raj Parikh, PRS Resident Ambassador from Washington University in St. Louis, and I'm joined by my co-resident ambassadors, Lily Mundy from Duke University and Kyle Sanniec from UT Southwestern. Today, we have the honor of being joined by Dr. David Song, Chairman of the Department of Plastic Surgery at Georgetown University Medical Center. Thank you so much, Dr. Song, for joining us for this PRS Journal Club podcast.
Oh, it's absolutely my pleasure. This is going to be great.
The articles that we will discuss can be read for free on prsjournal.com, including an archive of all past Journal Club articles. The article we will be discussing is Developing a Lymphatic Surgery Program, a first-year review by Dr. Singhal and Dr. Bernard Lee at Beth Israel Hospital in Boston, Massachusetts. I'll quickly summarize this paper and then we'll jump right in and get Dr. Song's thoughts on it. This paper talks about the establishment of a lymphedema program, a lymphatic surgery program at Beth Israel Medical Center, which was affiliated with the Harvard Medical School in Boston, Massachusetts. It discusses their experience establishing a program in 2016 and then describes their experience over the calendar year of 2017, describing how many consultations they evaluated, as well as how many patients converted to surgery, what surgeries they had, and the indications as well. And it really serves to outline a roadmap for other programs or physicians interested in starting a lymphatic surgery program. So they looked at a retrospective review of their clinical database from the calendar year 2017, so after they had some headway to get the program started. They looked at all individuals that presented to their institution. They recorded demographics, clinical characteristics, and then surgical management as mentioned. A total of 142 patients presented for evaluation for lymphatic surgery. The patients were on average 54 years old and then had a BMI of 30. A predominant amount of their patients were for breast cancer related issues, so either prophylactic treatment or treatment for chronic lymphedema. 32% of the patients that were evaluated underwent a procedure, and out of those, a majority of them, 2/3 were immediate lymphatic reconstructions or prophylactic, so to speak, lymphatic reconstructions. And in their first year, 94% of the patients that they were consulted for immediate lymphatic reconstruction did decide to have a procedure compared to patients for delayed lymphatic reconstruction. And they really kind of summarize their experience and go through some helpful hints for people interested in starting a program. I did find that a few things interesting. First, that there were a lot more procedures for immediate or prophylactic lymphatic reconstruction. So 71% of those procedures compared to only 29% delayed, as well as the amount of patients they saw for immediate was higher than for delayed. Furthermore, I thought it was very interesting that only 28% ultimately of patients that were evaluated did undergo a lymphatic surgery operation, which kind of emphasizes that when you're starting these programs, a lot of the patients may just be evaluated but may ultimately not require or proceed with surgery. So with that said, I think that summarizes the paper and the gist of the paper. I wanted to jump right in and get your thoughts, Dr. Song. As somebody who's been a chief and a chair at two different programs that have had emphasis on lymphedema surgery, what did you think of this paper and the setup at their institution, and what helpful advice would you have as somebody who's run these programs for other institutions interested in setting up a program?
This was a very good summary of what they did and how successful they've been. Clearly the things that stuck out were the patients that came in for immediate reconstruction. The vast majority, 90+% of them, underwent surgery. To me, that tells me that there's an amazing collaboration between the plastic surgery team and the surgical oncology team at the institution. It goes to show the inroads that they've made, not only from breast reconstruction, but perhaps new inroads for lower extremity lymphedema when they do ovarian cancer or any type of lower extremity type of reconstruction and lymphadenectomy. So that is a signal that the collaborative efforts have been wonderful. The interesting thing that I find is that having started a program in both Chicago and now here in DC, it's something very similar. When you get there, you know, we see everybody, and it's hard for our call centers to recognize what real lymphedema is, what lipedema is, what obesity is, what venous stasis is. You know, the sieve is large for patients that come in thinking they have lymphedema, and even if they do, they may not necessarily be candidates for some of the things that we're talking about with bypass or vascularized lymph node transfers or even debulking. So that does not surprise me that the delayed patient population was only a minority had surgery. The other aspect of this is insurance carriers and coverage. many in our region, both in my experience in Chicago and now the Mid-Atlantic region, many of the payers consider this still experimental or investigational surgery. And I was just on the phone last week with a carrier and their medical director going over all the data, and yet they still have not been convinced about the efficacy of these operations, in spite of the fact that I've sent them pictures, we have patient testimonies and so forth. So this is going to be a battle that we're going to need to continue to fight across the country, to have articles like this and more detailing the successes of this whole therapeutic modality and subspecialty within our field. So again, kudos to the authors for describing their journey. It's been a very similar journey that I've taken twice now, and it brought back a lot of memories as to how to successfully build one. Here at Georgetown, we now have 4 lymphatic surgeons, and I think we're sharing best practices with Bernie Lee, my old group back in Chicago, and a few groups on the West Coast, and the struggles that we all have are very similar when it comes to payer mix. It's interesting to note that many of us that are doing this now are starting to converge on a best practices of what modalities fit which patients. And while that's out of the scope of this paper, it's starting to coalesce and crystallize into a critical pathway, if you will, for certain patients.
Sure, that's great to hear, because I think some of the challenges, somewhat unrelated, but with lymphedema surgery, has been just figuring out kind of that algorithm, that treatment algorithm, and it seems that every center that does a high volume of this is doing something a little bit different. So getting that consensus would obviously be very meaningful. I think one of the other things I wanted to get your thoughts on, and you touched on this a little bit, is the immediate risk chronic or delayed lymphatic surgery group. And my assumption would be that at an institution such as BI, but even when you started at Georgetown, what your personal experiences were, that there would be a backlog, so to speak, of patients, especially with breast cancer-related lymphedema. But it seems from their experience, at least in this paper, that that wasn't the case. A lot of their referrals were either for immediate or from outside institutions for delayed reconstruction. So in your experience, did you see that when you started at Georgetown, that there was a lot of patients who just hadn't had the need fulfilled within the institution, or were a lot of your referrals also from outside institutions? And then how do you get the word out and build those relationships with other hospital systems and competing hospitals?
The journey that Dr. Singhal and his group outlined is very similar to many of us that are starting programs in different regions. Just to take a little bit of an aside, it's very interesting that many, if not most, major metropolitan areas, let alone smaller cities, they don't have, the groups that do lymphatic surgery on a regular basis. And it's heartening to hear that many groups are starting this up. But you're right. So when I first got to DC, and clearly in Chicago, there's just pent-up demand, and people, you get the word out, and all of a sudden, you're thinking that you're going to see 1 or 2 patients, and I see probably on average 10 to 15 new lymphedema patients a week, and that's just me. So that's not including my 3 other partners. So clearly there's a pent-up demand. And the other thing that we've done to get the word out more effectively is working with therapists. So going out and visiting therapists. We have conferences. We invite them to the operating room to see what they're doing. And we work with them because, as you know, lymphatic surgery, we don't exist on an island. The surgery is only part of the overall success stories of these patients. You have to intimately have a wonderful working relationship with the therapist. So I think it's a many-fold playbook, if you will, looking at the physiotherapists, the rehab doctors, getting the word out, working with therapists, getting the word out there. And we've done some public service announcements here. We've had some earned media coverage in the region with patient stories. And I think if you combine all those 3 things, you start to quickly realize how many patients will come.
Yeah, it's great to hear, even though you may struggle initially, that there is a road to success, so to speak. One of the other things I just wanted to ask you about were, do you think insurance is the biggest current challenge with building a lymphedema program? And then have you had, I know it sounds like you're still struggling a little bit with getting insurance to recognize this, but what other strategies have you had to work with insurance? Or do you just think that publishing more papers and getting more good data out there for them to review would be the best step forward?
I think the one-on-one opportunities to speak with medical directors is critical. And, without mentioning any payer names, I used to serve on the medical board for one of the payers in the Midwest, and they want to hear from us. And, they, at the same time of being responsible with their resources, they also want to make sure that they're protecting their patients. In spite of what we think of the maturity of lymphatic surgery now within our specialty, much of the public and many of our colleagues, let alone insurance carriers, they still don't know. And I think these are all opportunities when there's a denial. To me, I always see that as an opportunity to get on the phone. Part of the appeals process is not necessarily the appeal and the success of the appeal, but it's also the storytelling. It's talking about data. It's talking about the meta-analyses. It's talking about, this type of paper that in small incremental ways, this is how we get things done. And I think this is not new. I mean, we had this happen in the early 2000s with ADM. Now there's a code for it. We had this happen with microsurgery. Now there's S codes. So this will happen eventually. It's happening already. And it'll take concerted efforts and continued outcome studies to help to convince the entire nation.
Thank you. Yes, I completely agree. One thing that was interesting is that a lot of their surgeries were breast cancer related, and I think that's probably the most generalizable or externalizable experience. Have you found, in your experience, success with surgical oncology, melanoma, and lower extremity limb lymphedema? And then have you experienced any challenges with physician colleagues in getting referrals within your institution or even outside and having to convince them of the validity of lymphedema surgery?
I don't think they need that much convincing. In fact, having given grand rounds to gyn-onc groups and surgical oncology groups, they don't know we exist. Their literature does not necessarily speak to lymphatic surgery. So I've only been welcomed with open arms, kind of like, wow, you guys do that? And so in order to visualize the actual surgery, we've videotaped it, we have videos of LV bypasses, we have videos of vascularized lymph node transfers, we have videos proving that these channels are open after weeks to months. And then, of course, you show that with a pre-op and a post-op. And it's a compelling story. And so the convincing aspect of it has not been the struggle at all. It's actually been the insurance companies. And so this is such a population of patients that are underserved and there's no answer for, that once you give a grand rounds, I think it's a welcome outlet for a referral source. And I think that's not necessarily the rate limiting step for building a lymphatic program. I think it's really the insurance carriers.
Well, that's great to hear. Kyle and Lily, have you had any experience at your institutions with lymphedema surgery or programs that were set up during your residency? And then what thoughts did you have on this paper in general?
This is Lily. This has been a really interesting discussion. We have had one surgeon who's done a fair number of vascularized lymph node transfers, and now have a second surgeon who I believe is hoping to start doing some bypass procedures as well, but hasn't started yet. We don't have as integrated, I would say, a lymphedema program with some of the other lymphedema team members as described here. I think we have a little bit more because maybe there was just one surgeon and he sort of, just interfaced with the therapists individually, but we didn't have such an organized center. So I think this paper gives such a great example of, the different factors at play and how maybe there's a lot of benefits in sort of organizing and creating a center that has some more additional resources and protocols for managing patients. But yeah, I think it was, it was an interesting paper and I've really enjoyed our discussion of it so far.
Thanks, Lily. Kyle?
When I first started at UT, we did have an occasional surgeon doing lymphedema work. I don't think it was a true lymphedema program in the sense that all the stuff that you actually really need to build an all-encompassing lymphedema surgery program. We have had people dabble in it. Probably the most common thing is similar to this paper where while it's not exactly institutionalized, it does start with kind of more immediate stuff where you're taking lymph nodes and transferring them when you're doing breast reconstruction or things like that, and kind of post-mastectomy patients who have some lymphedema of an extremity. When I was thinking about the paper, though, and this is kind of more of a generalizable question, maybe Dr. Song can help us with this, is the hardest part is, they get all these consultations and only 30% end up getting converted to the OR. But you need this whole big infrastructure, I feel like, to do lymphedema surgery well or to really have a good lymphedema program. So how do you set up with like a hospital administrators who are looking at, this program and all the things that you need to set it up when they're looking at this kind of 30% conversion rate and things like that for the initial startup cost before you can get up and running?
That's a great question. I think the initial startup costs are actually not that high. I was fortunate that they purchased both at Chicago and here at Georgetown. They purchased we now have 3 Mitaka microscopes in our system, which is critical for LV bypasses. But outside of those costs, And remember, those microscopes can be used for other microsurgery, including for the neurosurgeon. So those are not difficult barriers. I think that the setup is your team in the clinic. So if you went to UT Southwestern or Duke or any Wash U, I mean, you said if you open a lymphedema clinic, the real problem is you're going to get a ton of patients. And how do you triage them? How do you get their throughput? Remember, many are going to come with lower extremity lymphedema, and they may be in wheelchairs, they may not be ambulatory, and you have to be able to screen those patients out. And that's a challenge, but we have a wonderful limb salvage wound center that we have, and so many of these patients come through there. So we're equipped to deal with that, and I think that one aspect of starting a lymphatic program, especially if you're going to do lower extremity lymphatic program, is to pair it up with a wound care clinic or a wound care team, because they're used to seeing these wounds, they're used to seeing large lower extremities with venous stasis and so forth. So that's a nice pairing. Obviously for breast reconstruction and upper extremity, you know, your breast clinic is going to be a great place to start as well. So I'll often see patients in the breast center, not necessarily in my clinic. But you're right, I think the administration, I mean, it's a whole nother service line for us. And it's generated, you know, a considerable amount of not just revenue, but goodwill, and we're serving a patient population that previously had no surgical option other than the Charles procedure. And so much of this is welcome. The data is getting better. The fidelity of what we're looking at and measuring is getting better. The therapy is getting better. So the whole field is improving by leaps and bounds. It's actually very exciting. It's kind of akin to when microsurgery first started and seeing a new flap every week. And we're starting to see this kind of information travel quickly and be vetted, and the group actually all across from Asia to East and West Coast to Europe. I mean, you know, my friends all over the world are now having these symposia and Facebook groups that talk about best practices. So that'll all help to converge into your administration and your hospital, understanding, wow, this is a valuable, it's not a dabble, it's an actual service line now, and we need to pay attention to it. And I think the economics are going to be there, but more importantly, the mission for the patient population is going to be there.
Thank you, Dr. Sanniec. I think with that, we will end the discussion of this article. Thank you, everyone, for a great discussion. If you like this podcast, please feel free to share with your colleagues and friends and rate us on the Apple iTunes Store. Also, remember to tune into the other 2 articles that we will be discussing on this month's podcast. Finally, please join us for our monthly journal club on Facebook, where we will be able to interact directly in real time with this month's selected articles' authors. Go ahead and like the Plastic and Reconstructive Surgery Facebook page if you have not already done so. That's where our monthly journal club takes place. And once again, thank you so much, Dr. Song, for joining us.
Absolutely my pleasure. Thank you, guys.
Thank you for listening to the award-winning PRS Journal Club podcast. Be sure to read all of the articles being discussed, including some of the classic pairings from the archives, for free on prsjournal.com.